Доброго вечора, українські радіаційні онкологи, медичні фізики. Слава Україні! Дуже дякуємо, що приєдналися до Research Methodology course for Ukraine. Our topic today is designing a prospective study, and we have a great speaker, Dr. Ugur Selek. He's a professor and past chair of Department of Radiation Oncology at Koç University School of Medicine and chair of Department of Radiation Oncology at BKV American Hospital in Istanbul, Turkey. Dr. Selek graduated from Hacettepe University School of Medicine in 1997 and was certified by ECFMG in USA. He completed his radiation oncology residency program at Hacettepe University in 2001. And between 2001 and 2003, he worked at the University of Texas MD Anderson Cancer Center and the Department of Radiation Oncology as a clinical fellow focusing on IMRT and SBIT. He was also awarded with the first annual MD Anderson Radiation Oncology Fellow Research Award in 2003. He was an adjunct faculty at UT MD Anderson Cancer Center, Department of Radiation Oncology, from January 2009 to December 2022. And Dr. Selek is the co-editor of 6 Springer books and has authored around 280 articles and book chapters. He was awarded as a Fellow of American Society for Radiation Oncology, ASTRO, in 2019. He is a Radiation Oncology Section National Delegate at the European Union of Medical Specialists since 2022. He is the past president of Turkish Society for Radiation Oncology and the current member of ASTRO International Committee. He has just been awarded with the 2024 Gold Medal of MD Anderson Alumni Gilbert Fletcher Society. Congratulations on all your awards, very impressive resume. We are honored to have you here, and thank you so much for preparing this lecture for our Ukrainian colleagues. We're really eager to learn from you today on designing a prospective study. The podium is yours. I will stop sharing.
Well, it's my great pleasure to be together with you, and thank you for your invitation. So let me share my screen.
Excellent.
Well, I believe you can see my slides.
Yes, we can.
Okay, perfect. So today I'd like to go over designing a prospective study, and as you have noted, it's approximately 45 to 50 minutes of a presentation. And these are my disclosures. No real conflict of interest for this presentation. And I'd like to start with a question. What's the primary advantage of a prospective study design in oncology research? Is it a less expensive than, or you have already asked that? Okay, perfect.
But you can read it out, so it's translated also simultaneously.
Perfect. So it's less expensive than retrospective studies. B, it avoids the need for ethical approval. C, it allows for real-time data collection and control over variables. D, it guarantees faster results. And E, it eliminates the need for statistical analysis. I believe everybody answered that, so I'm passing.
So we will wait until approximately 80% answers that we're taking attendance.
Okay.
So let's wait a little bit until people answer. It's the beginning of the lecture. People are still joining, I think, but yeah. Okay, so we have around 70%. I'm ending 78%, ending the poll, sharing results. So majority said, 80% said C.
C, yes. That is the correct answer. It allows for real-time data collection and control over variables. So why do we have prospective studies in oncology? Because there's a direct observation of outcomes after exposure and intervention. It's a stronger temporal relationship versus retrospective designs. We have an ability to minimize recall bias and clarify causal links in prospective studies. And foundation for clinical trials and real-world cohort studies are applicable. So the second question is, which of the following is not one of the key steps in planning a prospective study in clinical research? A, defining the research question and hypothesis. B, selecting the study population with inclusion and exclusion criteria. C, choosing an appropriate retrospective database. D, calculating sample size and statistical power. E, addressing ethical considerations and consent. So which one is not one of the key steps? So these questions will probably prepare you what we need to be focusing on during these slides and in my 45 minutes. So is it answered?
Yeah, so majority answered. So I'm sharing the result. So 60% chose option C.
Yes, so C is the correct one because it's not only including the retrospective database, because we are trying to do it prospectively. So key steps in planning a prospective study are mainly defining the research question and hypothesis, select study population, and inclusion and exclusion criteria for that population. We need to choose study design. Would it be a cohort or a longitudinal trial? We need to specify outcomes and measurement tools. We need to calculate sample size and statistical power. Again, we need to ensure the feasibility, the logistics and funding. But the most important step perhaps in this criteria is addressing the ethics, consent, and data monitoring in this prospective studies. So let's start with defining the research question and hypothesis. We generally name it as PICO framework. The population, the intervention, the comparison, and the outcome. We need 4 steps in defining the research question or hypothesis. And if we give an example from the recent trials like durvalumab after chemoradiotherapy in stage 3 non-small cell lung cancer, here the population is a newly diagnosed stage 3 non-small cell lung cancer. And the intervention is after chemoradiation, giving durvalumab consolidation as an option, as a test arm. The comparison is placebo, and the outcome, which is predefined, the progression-free survival in this group of patients when we compare them at the end as a final endpoint. The representatives and generalizability is important. So again, from the Pacific trial, the disease state is important. So which group of patients do we need to put enrolling in this prospective trial? The inclusion criteria is given as stage 3 unresectable non-small cell lung cancers. So we are giving a group of patients. They are stage 3A, stage 3B, stage 3C. It can be directly related with a T stage. It can be directly related with N stage. But overall, we are trying to not to narrow too much. So it's a broad stage 3 unresectable group. But we need to have an exclusion criteria. So we don't want to give an unnecessary consolidation treatment. So the exclusion criteria involves progression after concurrent chemoradiotherapy. So we are giving this medication, the consolidation treatment, to the group where we expect real benefit, not to the progressed group. And again, the organ function is very important. If these patients are not eligible for chemoradiation, if these patients are not eligible for a systemic immunotherapy, we need to eliminate them. So the adequate bone marrow and organ function is necessary. We need to exclude the group who requires systemic corticosteroids. And the pulmonary status, of course, is very important. No signs of disease progression post-chemoradiation is a must. They need to be suitable for immunotherapy. And if there is a group of patients who are prone to additional reactions like interstitial lung disease or non-infectious pneumonitis, they need to be removed. They need to be excluded. So the inclusion criteria and exclusion criteria needs to be based on not only the representatives and generalizability, but also specifically for the question and the group cohort we are choosing. So how to move? Choose the study design. The study design can be cohort or longitudinal. A cohort study is a type of observational study where a defined group of people is followed forward in time to assess how certain exposures affect the outcomes, such as smoking, such as drug use. The outcome is cancer, heart disease, etc. And the longitudinal study is a broader term that means repeatedly observing the same individuals over time, and it can be observational like a cohort or interventional like a randomized controlled trial. So the question comes, in a longitudinal cohort study, evaluating the development of secondary cancers in breast cancer survivors over 10 years, which of the following best describes the study design? A, patients are randomly assigned to receive different treatments. B, a group of patients is followed over time to observe future outcomes. C, a snapshot of cancer incidence is taken at a single time point. D, past records of patients are used to analyze treatment outcomes. E, patients are interviewed once to assess current treatment satisfaction. Please go ahead and answer.
So we have 62% answering. We're waiting for a little bit more answers, please. But I think majority are on the right track.
Okay. And
so I'm I'm sharing the results so they could see the majority 80% answered B.
B, perfect. So the right answer is B here. And let's move on. What are the differences between cohort and longitudinal studies? Cohort studies are always observational, but can be prospective or retrospective. Longitudinal studies refer to a time aspect. So we need repeated measures, and it can be a cohort, it can be a randomized trial, it can be hybrid. So nested designs are efficient for studying rare outcomes or costly lab tests within a cohort. Interventional studies are often prospective, but differ by randomized status. So I believe you will be sharing the slides, so I'm not going into detail of each table, but as a definition and study design, prospective cohort studies, longitudinal studies, prospective observational studies, randomized controlled studies, non-randomized prospective studies, or prospective case series, nested case control studies. It can be named a lot, and all these are actual effective trials. So we need to be choosing these trials based on our goals. In clinical studies, when we are doing them prospectively, there are three types of trials: phase 1 trials, phase 2, and phase 3 trials. In phase 1 trials, mainly, we don't know if it is safe, we don't know the optimal dose, so we are looking at that. So we are looking at the maximal tolerated dose, such as a radiation dose to the lung or a kidney, or are we trying a new medication? So those are all phase 1 trials. In phase 2, those from the phase 1, which was noted as safe, are tried in a larger population for safety, activity, and preliminary efficiency. But the most important one is the phase 3, because in the phase 3 trials, we have confirmatory efficacy, we have comparison with the standard of care, such as we have done in the durvalumab trial. The standard was at that time concurrent chemoradiation, and after that there was no adjuvant treatment, but adding immunotherapy and adjuvant treatment to that as a consolidation was tested in that trial. So in phase 1, the maximum tolerable dose, it can be a medication, it can be radiation, is based on the dose-limiting toxicity. It can be into two phases, algorithm-based or a model-based approach. Patients are openly treated with the medication or intervention being evaluated. And after that, when we gain a maximum tolerated dose, when we obtain that from phase 1, we test it in the phase 2. In phase 2, there are two parts, 2A and 2B. 2A is mainly proof of concept. And 2B, when we prove that concept, we based on that elevation to the next step and trying the dose response study. So in phase 2, those who have responded are randomly assigned to continue the same treatment or switch to a placebo. Usually non-compliers and adverse reactors identified in phase 1 are excluded from the phase 2 trial. Phase 2b can be a single arm, which is directly related with the response rate, but mainly most of the phase 2 trials are randomized trials. So randomized selection, randomized control, randomized discontinuation, and in this one, we have additional endpoints, not only the response rate, having progression-free survival, time to treatment failure. Sometimes we see overall survival, but that is mainly spared for phase 3 trials. Phase 2b can be done as a basket trial. A basket trial recruits patients with different types of cancer, such as lung cancer, kidney cancer, liver cancer, etc., who share a common molecular marker of progression pattern and tests a single intervention. It can be radiation, it can be a targeted treatment, it can be immunotherapy, and it's tested in all these kinds of tumors, like type A, type B, type C, the same approach to all different types. There are different examples here from phase 2b basket trials, such as Radiant. In Radiant, the radiotherapy role is SBRT to the progressive sites, and it was tested in many different sites, like prostate cancer, breast cancer, non-small cell lung cancer, renal cancer, and the design was single-arm, multi-center, phase 2 basket trial, having all oligoprogressive disease. The endpoint was site-specific progression-free survival based on the SBRT added to the oligoprogressive disease. So basket trial has one prescription, and here it is SBRT. The target is the oligoprogressive disease in all different types of cancers, and endpoint is site-specific progression-free. When we look at the iNature trial, and in this one, this is a phase 2 basket trial. It includes advanced solid tumors like melanoma, non-small cell lung cancer, colorectal cancer, and radiotherapy used here to augment individualized neoadjuvant vaccine, and endpoint is the immune response. So I'm not going into the details of the others. So one prescription, here it is SBRT or radiation, used in different types of cancers, and see the result and then move on based on that. This basket trial. The second approach is an umbrella trial. An umbrella trial studies multiple targeted therapies in a single cancer type. So just in lung cancer, just in colorectal cancer, just in breast cancer. Where radiotherapy may serve as a backbone or adjunct. Here the tumor is the same, the target is different, and we test it with the controls. The control arm can be doing nothing, and the test arm is SBRT or radiation in these different trials as umbrella trials. So Neptune umbrella trial has non-small lung cancer, so it's the one single cancer. It's a multi-arm phase 2b. So we add SBRT to targeted therapy arms. So EGFR arm, ALK arm, KRAS arm. So just the systemic treatment or adding SBRT to the targeted area. In Pandora trial, these are all head and neck cancers. So radiotherapy is the standard with de-escalation arms based on HPV positive or PD-L1 positivity. So I'm not going into details of the rest, so you will have the slides. So here, just one cancer, but different arms, and radiation as a tested arm is added to the systemic treatment. The third one is the randomized discontinuation trials. Randomized discontinuation trials often explore whether continuation or discontinuation of radiotherapy or combined therapy adds meaningful benefit with early stopping rules or futility analysis. For example, ECHORD trial. This is done in extrahepatic cholangiocarcinoma or gallbladder cancer. The role of radiation here is radiation plus immunotherapy versus control arm. They checked the discontinuation, so withdrawal rules for adverse events or lack of efficacy. In small cell lung cancer Atezo trial, it's done in limited stage small cell lung cancer. It's a randomized phase 2. The problem here is discontinuation alone after toxicity, and median time to the discontinuation is tested. There's thoracic radiation and chemoradiation, and then atezolizumab, and endpoint is progression-free survival or overall survival. And in the top floor, the follicular lymphoma is tested as a phase 2 trial. Obinutuzumab plus minus radiation arms are tested, and trial had early discontinuation in subgroups based on the toxicity and futility. Overall, the discontinuation trials tests futility stopping rules, toxicity-driven discontinuation, or adaptive withdrawal. And basically, especially when we test an immunotherapy and add radiation, like atezolizumab plus chemoradiation in small cell lung cancer, we try to see if it is toxic or not, whether the local control or progression-free survival is better with adding atezolizumab or not. And there is also a test of the recent innovations in radiation oncology. Where do we need to fit that? And so our ideal, it's generated by MR-Linac Consortium recently in 2017, gives us a different perspective of stage 1, 2A, 2B, 3, and 4, based on the innovations in radiation oncology. I mean, here it is directly related with MR-Linac, but it can be a PET-Linac. So the stage 2A here is the technical improvements and feasibility. Stage 2B is early effectiveness, like toxicity, tumor response. In stage 3, it's effectiveness compared to the standard treatment. So what are the examples? For example, when we are doing a stage A as a structured case report, MR-Linac delivered conventional palliative radiotherapy for metastatic esophageal cancer, or MR-Linac delivered neoadjuvant chemoradiation with reduced PTV margins, or stage 2B, 3B esophageal cancer. When we come to 2A, small prospective cohort studies of 10 to 20 patients with stage 1B, 3C esophageal cancer undergoing MR-Linac delivered neoadjuvant chemoradiation using a standard fractionation. In 2B, a randomized study is planned based on what MR-Linac treatment is compared with the conventional margins and conventional treatment. And in stage 3, a multi-center randomized control trial was planned to be tested. The question here is, what's the primary objective of a phase 3 clinical trial in oncology? It can be directly related with medicational treatment, or it can be based on our ideal. So A, to identify molecular biomarkers for future research. B, to determine the maximum tolerated dose of a new drug. C, to explore early signals of efficacy in a small group of patients. D, to compare a new treatment with standard therapy in a large population for efficacy and safety. E, to observe long-term incidence trends in the general population. So which one is the right answer for you? Okay, are we there yet?
We have 60%. Let's wait for a few more answers.
Of course.
Yeah. So ending the poll and sharing the results. So we have a D as the preferred choice, 75% answer D.
Yes, the D is the correct answer. We are trying to compare a new treatment with standard therapy in a large population for efficacy and safety. So how about calculating the sample size and statistical power? Is it important? Yes, it is. Because designing a prospective oncological trial demands integration of clinical relevance, statistical rigor, and operational feasibility. Modern techniques such as covariate adjustment, adaptive designs, and Bayesian methods often offer powerful alternatives to traditional fixed sample paradigms. However, at the end, we need a sample size and we need enough power to define what we are asking for. So the sample size is the number of subjects required in a study to detect a specified effect with a given level of confidence and power. Statistical power, which is named as 1 minus beta, the probability of detecting a true effect. And it's commonly given as 80% or 90%. The key parameters required for power analysis are mainly the effect size, alpha, power, baseline effect. I'm not a statistician, so I recommend getting help from a colleague who is good in statistics or a statistician. And basically, there are three types of calculations for power analysis. It can be binary. In binary, we generally try to look at a response. Continuous form, it generally requires a tumor size reduction. If you're looking at the time to event effect, like a progression-free survival, we need a difference power analysis. And in initial two, binary and continuous, we need a sample size at the end of calculation. But in time to events, we need to find the number of the events to define the sample size. So let me give you two simple examples, like a simplified example for a binary outcome. Let's assume a new therapy improves tumor response from 20% to 40%. So it's P1 is 20, P2 is 40, 20% to 40% in control arm and the treatment arms. Here, if you would like to have 80% power, and so beta is 0.2, and when we have a two-sided significance, we are searching for an alpha, it's 0.05. And in the formula below, when we place these numbers, at the end we get 79 patients needed on both arms to define the outcome and response, which is from 20% to 40%. The second example is time to event. Let's assume the standard treatment, it has a median overall survival of 12 months. And the test arm, we assume to gain 18 months at the end of 1 year. At the end of the treatment. So 12 months to 18 months. Hazard ratio is mainly calculated with the current treatment below the test arm. So the hazard ratio is 0.67, so 2/3. Power is again 80%, and the formulation below gives us the number of the patients required to calculate the total population. This is the number of the events if we are looking for 12 months versus 18 months as 14 events needed when we perform the calculation for the whole cohort. So what was the examples in the literature? Let's go ahead and see the durvalumab after chemoradiation in 2017 New England Journal of Medicine paper. It was estimated that the study would have a 95% or greater power to detect a hazard ratio for disease progression or that of 0.67 and 85% or greater power to detect a hazard ratio for that of 0.73. When you look at that, you can easily say that, well, they are expecting 1/3 of improvement in disease progression because the hazard ratio here is 0.67, and they are expecting approximately 30% benefit on that, because 0.73 as a hazard ratio for that means 7 patients on standard arm is living, 10 patients on the test arm is living. So approximately 702 patients were needed for this 2-to-1 randomization. And in order to obtain this, 458 progression-free survival events were necessary for primary analysis and for progression-free survival, and for the overall survival, the events needed is 491. Because it's a lung cancer, 700 patients are enough for this. However, it's not the case for the rest of the tumor groups, such as breast cancer. So it's important to see the feasibility, the size, the cost, the logistics, and the funding, because in the UK START trials A and B for breast cancer, the tested point is whether 50 gray in 25 fractions is comparable to 41.6 gray in 13 fractions, or in START B, 50 gray in 25 fractions is comparable to 40 gray in 15 fractions. and the results were equivalent local control, less toxin hypofractional arms. So, since these trials, hypofraction is a standard approach in the UK and globally. However, both of these studies required more than 2,000 patients just to test this. So 2,200 patients in START A and 2,200 patients in START B. And it's very, very expensive. The size, cost, logistics, and fund is very important. And it depends on the cohort. It depends on the power calculation. So what about plain data collection and follow-up schedule? Prospective data capture is very important. So we need to define the imaging, labs, toxicity assessments. We need to define use of electronics charts, central radiology view or not. We need to define the longitudinal components. So what should be the regular time points for? Would it be baseline, every 3 months, annually? Such as in the longitudinal follow-up of Checkmate 141, it's a head and neck cancer trial, the survival data was collected over 2 years. We have limitations for randomized controlled trials in radiation oncology. And most important one is the patient preference. I mean, it's very difficult to ask a patient whether he or she wants to be in randomized controlled trial, because when you roll the dice, they don't know if they're in the standard arm or in the test arm. And radiotherapy is very complex, and everybody knows that. There's a limited public understanding. The diseases with very poor outcomes over there, like liver cancer, like lung cancer. And we have very different treatment regimes from different departments for different countries. I mean, UK treatment trials might not be the same in US or in Turkey or in Ukraine. So changes and difference in practice is also very important when we try to standardize the treatments, because the difficulty setting control standards is there due to the volume definition in different centers, the dose fractionation in different centers, the imaging techniques in different centers, the PTV margin in different centers. Then the mission creep, early adaptation due to long follow-up times is a problem, and availability of technologies. You know, one department might have a PET-guided treatment, and the other one might have an MR-guided treatment, and the other has only conventional techniques, no IMRT, no VMAT. So that's a problem. And in these kind of situations, when there are limitations for randomized controlled trials, there are alternatives like external control data or real-world analysis. But the most important detail here is the generalizability. The research active centers, available technologies, learning curves, team and operator dependence is important. And also the diversity of the trial populations, including age, sex, ethnicity, and language is important. So there are 2 papers, recent papers. One of them is best practice for patient-centered radiotherapy in clinical trials. The other one is modernizing clinical trial eligibility criteria. I'm looking at this. So when the patient is seeking for a prescription alternative, let's say it can be SPRT, it can be a radiation approach, it can be a new medication. Is it toxic? The toxicity of experimental treatment. If it is a high or moderate or unknown, then we need to test the efficacy, effective, available prescription. If it is efficient, if it is not efficient, there are 2 different ways. If it is efficient, then the intent is curative or not. If it is a curative approach, then the decision requires specified lines of a prescription, and this is strongly advised. But if it is not a curative approach, and let's say the toxicity is very low, as you can see here, we can directly go ahead and try it as a pre-specified lines of prescription, not necessary for eligibility. But when we talk about generalizability, the documentation is very important. In many different departments, the documentation might not be the way. But if the documentation is not there, if the documentation is not detailed or standard or reliable, then the retrospective data might not be eligible for future studies. So best practice for centered radiotherapy in clinical trials and beyond was a multidisciplinary consensus proposal. It's saying that let's go ahead and do treatments as patient-centered information, with patient-centered information. Let's have the patient in the decision-making and have the informed consent. And the patient-centered outcomes can be important in the future if we document them in a reliable format. And they can be used as healthcare system data, and not, of course, replacing the randomized control trials, but if we have a very detailed population, if we have a very detailed treatment approach and documentation for toxicity, documentation for efficiency, it can be a good way of using our data. However, when we are doing this, the diversity is also important. Who should my trial results apply to? Are the groups identified in this question likely to respond to the treatment in different ways? Will my trial intervention or the comparator make it harder for any of the groups identified in this cohort? And will the way I have planned or designed make it harder for any of the groups identified in this cohort? So these are critical questions to see the diversity of the trial. And when we are also searching for a diversity or a future design of the trial, a roadmap including the research investigator, funding options, the dynamic study delivery, study closure, and impact analysis at the end, they need to be detailed from the beginning. So what about the external control data? Let's say we cannot do prospective randomized trials, but we already know that durvalumab trial was there. They have a control arm, they have a test arm. So if we are doing the same approach with the same inclusion criteria, with the same exclusion criteria, with the same treatment approach, can we compare them? If we are well documenting, yes, we can. So we can compare what we do with a previously detailed phase 2 or phase 3 data, and it's called external control data, but they need additional questions whether our data is really mirroring that test results, and are we really documenting them for toxicity, for outcome, and in the same standard approach. Such as in the neuro-oncology trials, external control data has been started to be used more because the number of patients are limited. So we cannot assign 500 patients on one arm, 500 patients on the other arm to test it for a long time. But if you have a trial data already presented there, we can compare a new medication or a new approach based on what has been previously reported. But this needs to be detailed properly and needs IRB approval. So when we come to addressing ethics, consent, and data monitoring, we need to have an institutional review board approval, and we need to have an informed consent. This is a must. Patient safety monitoring is a must. And we need to comply with the good clinical practice, and if we can, if it is eligible, if it is reasonable in the country you are working in, we need to register these trials. And the most important point here is specifying the outcomes and measurement tools. What do I mean? We need to have solid endpoints to test mortality, morbidity, quality of life. If you're looking at the final endpoints, it can be patient-related or tumor-related, like overall survival or quality of life. For tumor-related ones, time to endpoints on response might be important. But can we wait 5 years for the final endpoints and to see the survival results? In recent years, with lots of technological and drug developments, sometimes it's very difficult to do that. So we need some intermediate endpoints. Question here is, in prospective clinical oncological trials, which of the following best defines a final endpoint? A laboratory biomarker used to estimate early treatment activity. B, a pre-specified clinically meaningful outcome that reflects the true benefit or harm of a treatment. C, an imaging-based tumor response observed within the first treatment cycle. D, a subjective report of quality of life improvements during this treatment. E, an early time to event metric used to shorten trial duration. So which one is true in your perspective? Are we there yet?
No, waiting for people to respond. Only 34% so far. So waiting for, it's a little bit long answer. So waiting for them to read it through.
So here the correct answer is, because I believe most of the people have already answered that, is the B. So it's a pre-specified, 87% marked
Answer
as B. Perfect. So a pre-specified clinically meaningful outcome that reflects the true benefit or harm of a treatment is considered the best final endpoint. So final endpoints in a prospective trial refers to the ultimate pre-specified outcomes that measure whether the experimental intervention achieved its intended effect. They differ from intermediate or surrogate endpoints because they represent the clinically meaningful long-term results. So final endpoints are trial outcomes that reflect the true clinical benefit or harm of a treatment used to guide regulatory approval, a clinical practice, or health policy. So what are we looking at? The general survival and quality of life. On the other hand, we need intermediate endpoints because outcomes measured before the final endpoint occurs, and we need them because they serve as early indicators of whether the intervention is working or not, may correlate with, but not always equivalent to the final outcome, and they help assess treatment efficacy earlier, to reduce trial duration, to guide go, no-go decisions. What do we have in hand? As a response, we have complete response, objective response, response duration, clinical control, and clinical benefit. I'll go into details of these. And time to endpoints are important to have an intermediate endpoint. So why they are important? Because we need faster readouts than overall survival. They are important and they are used in phase 2B randomized discontinuation or adaptive design to determine whether to continue the medication or radiotherapy or stop. Regulatory context is important when we try to name as surrogate endpoints. The surrogate endpoint is strong enough to validate the overall survival or distant metastasis-free survival, such as in the prostate cancer. Distant metastasis-free survival in prostate cancer is a direct surrogate for overall survival. It can be radiotherapy specific, such as intermediate endpoints, often to guide the dose of fractionation, like local control rate at 1 year. Tumor response, disease control, biomarker endpoints, functional endpoints, composite early events, they can be examples to these, like pulmonary function after radiation treatment or cognitive decline after brain radiation. These are the functional endpoints to test the trial. So, but we are not really looking at the quality of life at the end or the overall survival at the end. When we look at the intermediate endpoints, the examples can be non-small cell lung cancer, chemoradiation, and immunotherapy. The intermediate endpoint is 12-month progression-free survival, but the final endpoint is overall survival at the end. In rectal cancer neoadjuvant radiation plus chemo trials, intermediate endpoint can be the pathologic complete response just after the surgery, but the final endpoint is disease-free survival, again, general survival. And in brain radiation neuroprotection studies, the cognitive function at 6 months is an intermediate endpoint, but the final endpoint is long-term quality of life or survival. There are some critical details we need to know in response as intermediate endpoint. When we talk about complete response, this means that the disease disappearance rate. When we talk about objective response, we are talking about complete response and the partial response, but there is no stable disease here. It's not the objective response does not include the stable disease. The response duration is important. It's time to progression after treatment. And when we are talking about the stable disease, we are talking about the disease control. So it's complete response, partial response, and stable disease. This is considered disease control. And there's also a clinical benefit as a response arm. This is disease control at the end of the 24th week. It's mainly checked as the response of the drug, response of radiation, etc. As a quality of life analysis, it's very difficult. You know, we cannot really do URTC analysis, RTOG analysis at each case. But the easier thing in many departments is the time to deterioration, and it can easily be checked, such as in this trial considering atezolizumab plus beva versus sorafenib. In this trial, the locally advanced or metastatic unresectable hepatocellular cancers are tested, and the quality of life was based on median time to deterioration, and atezolizumab is better than sorafenib. So they didn't use the URTC or RTOG scales, but they just take the deterioration, and median time to deterioration is used as a quality of life analysis. Another example is the prostate cancer. The meta-analysis defines that the surrogate intermediate endpoint can easily be the distant metastasis-free survival for prostate cancer. Because, as you know, prostate cancer patients live long, and it's very difficult to compare the general survival when we are treating them with radiation or with surgery. But metastasis-free survival is a direct intermediate endpoint, a surrogate marker for overall survival in this group of patients. However, correlation does not prove causality, such as in breast cancer. Pathologic complete response in breast cancer was thought to be meeting the final overall survival goal, but it was seen that it's not meeting it. So it is revisited, and pathologic complete response failed to correlate with overall survival. So this means that in breast cancer, pathologic complete response is not a good surrogate. What about objective response, which was not including the stable disease? It's just complete response and partial response. So if you are using a phase 2 trial with an objective response rate, that means that we are not using a surrogate, a good surrogate for overall survival. And you can see many trials tested that before. It's not a reliable surrogate, such as in TAS-102 for refractory metastatic colorectal cancers. They use TAS-102, and they have seen that the objective response is only 1.6% in comparison to 0.4 with placebo. But the disease control at the end, which is including the stable disease, is 44% in TAS arm, but 16% in the placebo arm. So the stable disease needs to be there. So it's disease control, not the objective response, and it's a valid clinical trial endpoint as a surrogate. Such as in osimertinib plus consolidative radiotherapy for advanced EGFR mutant non-small cell lung cancer. Here, the consolidative radiotherapy together with osimertinib was tested. Local consolidation treatment to residual disease after osimertinib treatment defined the median intracranial progression-free survival was extended, and radiotherapy had delaying the systemic therapy switch here. So it's a valid, the local control is a valid time to progression response duration surrogate. And in another trial with an MR-Linac, synchronous oligometastatic prostate cancer was treated. And here the design was prospective study combining advanced radiation delivered systemic therapy, and the response duration improved by ablating resistant clones. So it's a good endpoint, good surrogate for final endpoint. In another trial, metastatic directed radiotherapy in clear cell renal cell carcinoma was tested with radiation, and the endpoint is local progression-free survival at the irradiated sites, and it was found to be a good surrogate. So it's a radiotherapy prolonged time to systemic progression without concurrent systemic therapy. So that response duration here, which is called time to progression, is a good surrogate. The clinical benefit, which I noted a couple of slides before, the disease control at 24th month, it's also a good, valid approach, such as in this endocrine therapy of premenopausal HER2-positive patient group. Palbociclib and fulvestrant was compared to fulvestrant, and at the end it was seen that it's an effective treatment looking at the 24th week results. So what are the time endpoints, such as progression-free survival? Progression-free survival is time to any progression or death since randomization. So we start the treatment and the patient progressed. This progression might be radiological, clinical, or death. And this is the first progression. So it is PFS1. It captures direct effect of experimental therapy until the first regression. But we also have PFS2. It is after the first progression, we wait for the second progression with a second treatment. And when we calculate that, this PFS2 starts from the time of the randomization, not at the end of the first failure. There are many trials that you can see the PFS1 and PFS2, like Bolero trial, Paloma trial, Mona Lisa trial. Here, the PFS1 outcome and PFS2 outcome are mainly meeting the final goal, like the overall survival outcome. PFS1 is important, and in these papers, PFS2 is also important because we need to see whether after the first failure, these patients are doing well to the second failure. What about the disease-free survival? Disease-free survival also includes the death, and this recurrence is radiological recurrence or death. So disease-free survival is named as time to recurrence or death since randomization. And we generally use this in adjuvant means. And there's another definition, event-free survival. This is time to disease progression, recurrence, or death since randomization. And this is generally tested as adjuvant or neoadjuvant setting. So you can use the disease-free survival or event-free survival, but the real way of using the disease-free survival is mainly in the adjuvant setting, but event-free survival can work in adjuvant or neoadjuvant. What about time to progression? If we are not looking at the death, that means that we are looking at time to progression. The death is not considered here. So it is time to any progression since randomization. What about the toxicity? And how do we name when we stop the treatment due to the toxicity? It is called time to treatment failure because it is including both any recurrence or death and also the toxicity to stop the treatment. It's called time to treatment failure, time to stop the treatment due to any cause, including the toxicity. It's a time to treatment failure. And it can be TTF1, it can be TTF2. So summary, primary endpoints, they are the main outcomes in a trial. They address the central hypothesis. There can be one, sometimes two primary endpoints. We cannot have 5 primary endpoints. But when we come to the secondary endpoints, these are additional supportive evidence, but are not the main driver of the trials. So they are used to explore broader treatment effects and mechanisms, may guide future research, health economics, and quality of life decisions. As a summary in this table, you can easily see the primary endpoint and secondary endpoints and the regulatory weight of it. Overall, we have a test question. We are trying to look at the primary endpoint, and we are trying to find that primary endpoint based on the study cohort, and we try to test the true effect, false negativity, power, based on assuming no difference or assuming the difference hypothesis. There are many different trials in the literature. They might be using response rate or progression-free survival in general in phase 2. In phase 3, it can be progression-free survival or overall survival in different cancers. And how do we specify and standardize the measurement tools? Let's take PACIFIC again. Here, if we are testing something, it needs to be tested not only appropriately, but also in a standardized ways. I mean, if we don't have a RECIST criteria, when we evaluate the PET-CT or the lung thoracic CT, it can differ. I mean, the response might be differing from one radiologist to another. But if they're using the RECIST criteria, so we can easily define the tumor progression in a standardized and feasible way. The objective response is also important, and it needs to be tested based on a criteria. And in the Pacific trial, that's done for RECIST with RECIST. And here, if you are looking at patient-reported outcomes, it needs to be based on not only the referring physician. I mean, based on a physician, the patient was in perfect shape. But do we know what is the current status of the patient based on EORTC, QLC, C30? No. So we need to be knowing whether we are testing appropriately the patient-reported outcomes in a phase 2 or phase 3 trial we are using, and it needs to be feasible and needs to be standardized. So key steps in planning a prospective study is defining the research question hypothesis, selecting the population, having inclusion-exclusion criteria, choosing study design, specimen outcomes, calculate example and statistical power, ensure feasibility, logistics and funding, and address ethics, consent, and data monitoring. So I am done for the lecture parts, and I was provided 2 proposals, and I was asked to do some critics on those 2 proposals. And let me go on and try to explain what I think relate with those 2 proposals. The first proposal was the use of inhalation anesthesia during brachytherapy in patients with locally advanced cervical cancer. Here, the research question was to evaluate the clinical effectiveness of the treatment, pain relief effect, procedure duration, patient comfort, satisfaction, etc., under Umarox inhalation anesthesia compared to another type of anesthesia. The sample size was, considered as 60 patients. There is a group A inhalation anesthesia with Umarox, group B alternative anesthesia method. I'm not going into the details of the rest. So this is what I told and my recommendations. The title was a vague comparator because we need to clarify the anesthesia type in this one. The control arm was not described clearly. We need to specify the comparator anesthesia. The randomization was undetailed. There's a risk of bias, so we need to describe randomization in blind outcome assessors. The sample size was just 60 patients. We don't know what power calculation was used. So we need to justify with effect size and power analysis. The inclusion criteria not defined. The outcomes, it lacks validated metrics. So we need to add quality of life tools and adverse event definitions. The follow-up, in my perspective, is very short. So we need to add a little bit longer time after the first day, because sometimes the anesthesia might cause longer adverse events. The budget was incomplete. We need to, in this budget, we need to include the personnel, we need to include the monitoring, we need to see the data costs, and the ethics is missing. We need to have a trial registration and trial data privacy, and we need to have we need to add an ethics protocol and registration plan. So I tried to give them one by one, such as the title might be a prospective randomized control trial comparing inhalational versus intravenous anesthesia in brachytherapy for cervical cancer. In control arm, we can say, we can clearly define like whether we are using propofol IV sedation or spinal anesthesia or ketamine-based protocol. I'm not going into details of this. For sample size, we definitely need a power analysis. How do we know 60 patients are enough for this study? And the budget and cost needs to be calculated, because here only the Umarex cost is listed, but we need to add the comprehensive budget, including the personal cost, equipment use, data collection of statistical software, etc., etc. So the second proposal was a prospective one again. It is low dose rate pain treatment. The title was Efficacy of Low Dose Rate Radiation Therapy in Managing Acute and Chronic Neuropathic Pain Following Combat-Related Limb Amputations, a Prospective Randomized Controlled Trial During the War in Ukraine. Here, the number of the methodology is given. Inclusion criteria, exclusion criteria were there. the intervention is the fractionated low-dose rate radiation to the stump area, to reflexogenic zones, the sympathetic ganglia, and timeline and budget was estimated as $2,000. And this is the short summary of my criticism and my recommendation. The title is very long and verbose. We need to shorten it and sharpen it. The hypothesis is not clearly stated. We need to add a formal hypothesis. The sample size, again, no power calculation. We need to perform a calculation. We can easily calculate it through AI, through websites like MD Anderson or Stanford. We need to have a control arm, and we need to define it. We need objective quality of life definitions for pain outcomes. And the imaging, there are too much details for the imaging, but it's a very high burden in a very complicated status. So we need to define the minimum necessary. So when we go one by one, as a suggestion for title, low-dose radiation therapy for combat-related neuropathic limb pain, a prospective randomized controlled trial in Ukraine. The sample size, 50 patients on each arm, is not really detailing what is necessary. It's inconclusive. We need to have a power calculation, such as for a specific endpoint, like more than 2% for more than 30% pain reduction on this arm, we need this number of patients on this arm. Randomization is very important. If we are randomizing these patients, we need to use a centralized randomization because there is a real bias in hurt patients like this, in this chaos, in that cohort. Again, the outcome measures are weak, so we need to add additional validated tools such as brief pain inventory, pain disability index, etc. And again, we need to define the minimum required imaging. The budget needs to consider the hidden costs like personal time, imaging costs, transport, logistics for patients. And perhaps we need to explore external funding like WHO, IAEA, military medical NGOs. We need to, again, we need to have a statistical plan. It's vague. I'm not a statistician, so I cannot give you details about that, but it needs to be given properly. And overall, I tried to give details of a very long topic of designing a prospective study in this 50 minutes. And with a couple of questions, with 2 proposals and criticism and recommendations based on that. Thank you very much for your time and for your understanding. I'm open for any questions that I can answer.
Thank you so much, Dr. Selek. That was a very nice, very detailed lecture, lots of great examples. And thank you so much for reviewing those proposals and suggesting for improvements. And I'm wondering if the authors of those proposals are online and they can comment or ask questions. Please ask your questions because that's your chance to have
please,
some mentoring.
Please, share my slides with
definitely.
with the colleagues, and they can, let me rephrase something. I'm not a statistician. I am I'm a basic clinician. But I have been in.
None of us are, right?
I'm in these designs of clinical trials for a long time. So I have an understanding and I have a perspective, but I cannot say that 100% of all this presentation is right and correct. So please give your perspective and talk with a statistician and shoot your questions. If I can answer them, I'm here.
So I see some comments. Thank you, dear Dr. Selek. Thank you for the great talk and your advice. And this is coming from the people who designed the studies. So thank you for the lecture and advice about the projects. I think it was very, very useful for them to hear. How would you improve it? We definitely know that we have to do the statistical analysis and then calculate the sample size. So Dr. Martanius, do you want to say, does she design the study?
Yeah, I removed all the names because I didn't know who.
No, that's okay. It's known, but I think it was very useful to hear your feedback.
Yeah, thank you so much. It was fantastic because we are still not sure about design of our project and
right. Yeah.
How it would
we're just starting, right? So we will improve, but this
a
takes
little bit
time.
So thank you for the precious advices. Thank you so much.
Because we can really criticize any phase 2 trial, any phase 3 trial, which has been published in Lancet.
Yes, yeah, we can criticize anything.
Yes, criticism is something, but trying
how
to do something,
improve it, how to improve,
is another thing. These are all sincere and how can I say that? Recommendations to improve your study. And it will be there. It will be a really nice study at the end, but it's very difficult at the end when you are trying to write the papers and seeing, well, I did the statistics, but if I were if I would be doing it now, I would probably be taking another data set or a number of patients, etc. Because I have done that before, when years ago. So trying to figure out and trying to think that you are writing that data for a paper submission. So think what the reviewers can ask. Think about what might be lacking, and you cannot, and none of us can provide a perfect study. I mean, it's impossible, but we can easily do a study which can be published and which can make our clinical work more standardized and more efficient.
Dr. Marcenius, do you want to ask any questions?
No, I for now, no, but if it will be possible to emailing, so it will be fantastic for us.
Oh, that would be great. Dr. Selek, is that okay? They email you?
Yeah, of course.
Or follow up? Yeah.
When I can easily help also the reviewing of the details in the future, in the process of writing, submission.
That's awesome.
Because all the rest are very different and difficult processes. And we have been doing that for a long time with our residents and with our young colleagues. Why not with you? I can do it, of course.
Thank you so much. Thank you. Really appreciate it. Ruslan, you have a question?
Yes, thank you for great lecture. I have a criticism. I have a very general question. Ukraine is in war now, and is it the best choice for clinical trials? I mean, it is the best to have a prospective study in unstable countries. Because I think, for example, a longitudinal cohort study have a lot of risks in such countries. So maybe some retrospective studies is the best choice.
That's a good
What do you
question.
think about
So the country in war, right?
Yeah.
Yeah, a lot of
What do you
risks that
think?
this study was not successful.
Will not be successful, yeah. What do you think about this?
Well, in many different countries, there are many obstacles. I can understand that. But the point here is, in many retrospective data sets, most of the details are missing. I mean, yes, you can collect, let's say, all non-small cell lung cancers treated in the last 10 years. But what is the hypothesis there? What are you trying to look at that? I mean, what is the documentation required there? Was it given dose? What was the technique? So it's very difficult, but sometimes there might be very specific questions like, what is the pathologic complete response in our neoadjuvant treatments in our rectal cancer patients? Because you can easily reach the pathology, you can easily reach the operation note, you can easily reach the radiation dose. So when you are doing your retrospective studies, the question, the hypothesis needs to be balanced and needs to be, how can I say that, possible, you know, because
This
we can,
is success at the end, right? So
yes,
you try to work from backwards from the end,
yes,
right?
yes.
Yeah.
So in Turkey, many departments are trying to collect data prospectively with but they're not doing a prospective randomized trial. But
A registry,
yeah,
right?
so they are trying to do to do a registry with the, how can I say that, the details like the volume, dose,
Right.
toxicity.
Collect all this information
Yes,
prospectively.
and then ask a question based on what they have in their hands.
Right.
That retrospective study is easier. You know, my suggestion can be, you can come together in your national congresses and discuss the standardized approach for different types of cancers. For example, you can write a prospective
Guidelines.
guideline
Yeah.
and say that our contours needs to be based on that. Our dose needs to be based on this. We can check the toxicity with this quality of life data, let's say from EORTC or RTOG. But if every department will be doing that prospectively, at the end, let's say in 2 years, you will have some reliable data. And you can combine it. Because now, if you would like to have a multi-departmental study retrospectively, the data you will recruit from different departments will be all around.
Heterogeneous.
Yeah, it will be very heterogeneous. So my suggestion is not focus on retrospective data now, but try to focus on prospective multi-departmental guidelines to have reliable data in near future.
And I think it's good anyways to standardize and make sure that the patient that's treated in Kyiv is going to be treated similarly to patient treated in Ivano-Frankivsk, for example. Right?
Absolutely.
Well, thank you for that answer. There's also a question in the chat from the project about the pain. So what are the views on possible assessment of pain? How would you assess the pain?
You know, here, you know, brief pain inventory, pain disability index, EQ50, SF36, etc., etc. I mean, there are many. I generally recommend not only one selection. In an approach like this, I try to combine it with a second one to have more stronger valid data, and you can easily see that which one is working more for your group of patients.
Use different scales and
use
then
different
compare.
scales, not only just one, because sometimes you will realize that your cohort would probably be more prone to answer one scale correct or more clinically feasible way in comparison to the other one, because in some scales it's only 4 questions, in the other one's 10 questions, and the patient doesn't want to answer all of them at each weekly sees. But when you ask, let's say, easy 4 questions, it's faster, but it might not be true. So, but if you combine both of them, you can see if there are any variances, which one is better to be used in the future. You will see that in, let's say, in 10 patients or 15 patients easily. And we have more reliable data.
Okay, thank you. Any more questions from the audience? If not, I will ask a final question. So obviously running a clinical trial, especially phase 3 trial, takes a long time. And if it's a disease with a long overall survival, like lymphoma, it takes years and decades. You have to have a lot of patience. So how do you balance of reporting very good outcomes, like overall survival? That's very, very important, right? With that's time that takes to run the trial. How do you correctly balance it?
Well,
is there a more efficient way to do it? Maybe like with AI helping us, like how to stratify patients. Like,
well,
what's the future?
Yeah, there's a dilemma here. And there's a bias because most of the phase 3 trials are requiring lots of funding. And
a lot of patients.
Pharma, and pharma and the industry is backing up, supporting many trials. But in those trials, you cannot really ask a direct question when you really need, because of the pharma which is supporting the trial. And at the end, it's phase 3 trial, and at the end of 5 years, you're getting a result. But I don't think that radiation oncologists alone, or medical oncologists and radiation oncologists alone, or as a multidisciplinary approach, we cannot really do phase 3 trials without that funding. So my suggestion would be in the future having well-documented information, such as I noted in one of my slides. We need to standardize the data we are having in our departments, and it needs to be standardized in almost all departments to have a retrospective, good, solid, real-world data. And we can look at that as a big data, and we can use AI to get enough. How can I say that? We can have hypothesis, and we can extract the data from that well-documented information, which we have already documented and saved in our servers, like the one in the multidisciplinary national consensus proposal, which was in 2025 in Clinical Oncology Journal, best practice for patient-centered radiotherapy in clinical trials and beyond. It's a very good multidisciplinary consensus proposal. If we can collect that data, we can easily use that data, and we can compare that data with the arms of the previous randomized control trials, because it will be a large sample size, it will be maximizing the representativeness, there will be a potential for longitudinal data. It can identify disparities in care, because it can be different from one patient to another or one region from another. But it will be very efficient because the data will be there. You will just ask questions, the hypothesis, etc.
Yeah, and they are doing the registry actually. So they are treating their patients and enrolling them on the registry so they can easily analyze it. At least for MR guided RT, that will have that. That's amazing. That's great. Okay, thank you so much for such an excellent lecture. Thank you, I really
Thank
appreciate
you very
it.
much. And
Thank you.
I hope my pronunciation was
No,
okay.
it was
That's okay.
great. Yeah,
Okay.
right?
Thank you.
Yeah, very
Thank you very
good.
much.
Thank you so
So
much.
thank you
So,
for the invitation. It's a great pleasure to be together with you and supporting you.
oh, thank you so much. Thank you for supporting Ukraine, and I guess we'll see you at Astro. Are you coming
Yeah,
to
of
Astro?
course. In Astro, in general, I generally ask at the end of these Zoom meetings, I ask for a photo.
Oh, yeah, let's have a photo. If
Yeah, let's
people
have a
can
photo
turn
all
on.
together if it is possible. And can we open our cams? I mean, if it is possible, you know.
Yeah, let's do it. That would be great.
And would you please take the photo and share with all of us?
Yes, I will take a photo and share with all of you. Yes, definitely. Thank you for this suggestion. It's late in Ukraine. It's already 9 p.m.
Perfect. And you will have, you know, at the end, you will have a good collection of photos that you can say that we were together. So, see
Yeah,
you in
virtually.
San Francisco.
That's right.
Okay.